This presentation, titled Optical Point-of-Care Testing for Reagent-Free and Non-Destructive Diagnosis, is brought to you by the University of California, Davis, Lawrence Livermore National Laboratory Point-of-Care Technology Center. We are a National Institute of Health funded site, specifically by NIBIB. This is Nam Tran speaking. I am a postdoctoral fellow in the center, and today we'll focus on these point-of-care technologies, which are also presented here on this slide at our nonprofit YouTube site at www.youtube.com/POCTCTR, all in one word. Our lecture outline is as follows. First, we will introduce point-of-care testing. We will define it and identify the purpose of point-of-care testing in the clinical setting. Next, we will then lead into the principles and clinical applications of point-of-care optical biodetection, specifically in the context of nucleic acid recognition, glucose testing, non-invasive oxygen saturation monitoring, and then discuss what confounding variables can cause erroneous or discrepant results among these types of technologies. And then we will conclude with a brief summary of what is important amongst these topics and what is yet to come, and then segue into future directions in terms of reagent-less and non-destructive diagnostic technologies. Our learning objectives are shown here. The goal is, of course, to define what point-of-care testing is, what therapeutic turnaround time does to the clinical setting and outcomes. We will identify point-of-care testing formats, understand the principles and clinical applications of the three examples that I provide today: nucleic acid testing, photometric glucose biosensors, and non-invasive oxygen saturation monitoring. Also, we will understand the challenges caused by confounding factors in biosensor design. And lastly, we are to become aware, after this lecture, of future optical point-of-care testing methods. This slide shows a variety of point-of-care testing devices, specifically their formats. You see handheld, portable, transportable, benchtop, monitoring, and disposable devices. Starting at the top with handheld devices, these devices are small enough to fit in one's hand, as the name implies. They are usually battery operated. They may be strip or cartridge based for sample testing. In the center of this top category for handheld is an instrument known as the iStat. It is a handheld whole blood analyzer which looks at a variety of analytes, including cardiac biomarkers, markers for coagulation, glucose, as well as electrolytes and metabolites. On the upper left of this category, we have a handheld glucose meter. And then on the upper right, we have a unique instrument, a product of Lawrence Livermore National Laboratories, called the Handheld Nucleic Acid Analyzer, or HANA, H-A-N-A-A. And this device targets biothreat agents such as anthrax. Moving on, going clockwise, we have portable devices. These devices are a little bit larger than the handheld devices and approaches the size of a laptop. They may be battery operated for transient power loss, but however, most of the time they are plugged into an electrical outlet. The device at the bottom of the portable device category is analogous to the iStat that I showed previously. It is a little bit larger, has a carrying handle for mobility, and uses the same analytes for testing. Moving upwards, the little device that has a card being inserted by the user is an electrolyte point-of-care test. And then at the very top of the portable device category is a cardiac biomarker test. Again, as stated, this looks for a variety of enzymes such as cardiac troponin T or I, and these markers are released during myocardial heart muscle damage following acute myocardial infarction or heart attack. Moving on, we have transportable devices. These devices are rather large, therefore they are not capable of being transported by a single person. Therefore, they are usually wheeled around on a cart, as shown in this picture. This instrument here is a large whole blood analyzer called the Fox, PHOX, by Novo Biomedical. So oftentimes these are used in satellite laboratories as well as operating rooms as needed. Continuing on, we have benchtop devices. This is a subcategory of the transportable devices group. They are just shown here just to give an overview of the diversity within this point of care format category. Next, we have monitoring devices. These are very interesting devices which plug into an indwelling catheter, so a line that's connected into the circulatory system of the patient. It provides real-time monitoring of electrolytes, for example, in blood gases. They are commonly used in neonates and pediatric patients, as shown in the device in the bottom. The device in the blue device, shown in the upper right of this category, is a insulin pump for wireless interface with a continuous glucose monitor. The glucose monitor measures glucose levels every few seconds to minutes, and then this insulin pump wirelessly communicates with this device to adjust insulin infusion rates based on the most recent glucose results. So as a type 1 diabetic, you won't have to worry about adjusting a dose and sticking yourself with a syringe after a meal or so forth. Lastly, we have disposable devices. These may be the most familiar and most widely used devices for point-of-care testing. They encompass a variety of analytes. In the case of the bottom left-hand corner, we have a device that looks at glycosylated hemoglobin, specifically hemoglobin A1C. This test specifically targets or identifies how well a patient has maintained their blood glucose over a time interval of weeks or months. On the right, we have cardiac biomarker tests. These are immunoassay based and they are qualitative in nature. They again look for the same types of cardiac biomarkers, including cardiac troponin I, myoglobin, and CKMB. And at the top, we have a very interesting disposable device, which is a HIV 1 and 2 test, which is based off of oral swabs, which is rather easy to use. Of course, these devices, which appear to be for hospital use only, are not limited to the hospital environment. As we see on the next slide, point of care special applications, these devices have been used in disaster response. This slide was based on a survey we conducted during and following Hurricane Katrina. You can see that the United States military, specifically the Army, Air Force, and Navy, are frequent users of point-of-care testing, including for ABO blood typing, cardiac biomarker testing. The iStat device shown on the right, it appears again. Also for coagulation testing. The device below the iStat, the Piccolo, is essentially analogous to the iStat. It's a benchtop device. Does a little bit more analytes than the iStat. And of course we have our glucose meters, which are numerous, specific here, shown here. 45,000 were donated to the local Red Cross. And the U.S. Air Force also uses point-of-care testing for drug of abuse testing. So we can now define point-of-care testing as diagnostic testing at or near the site of patient care. It does not depend on the type of instrument. The goal is to improve medical and economic outcomes and to decrease therapeutic turnaround time. We define therapeutic turnaround time as the test order to patient treatment. This next slide shows how therapeutic turnaround time can be reduced when using point-of-care testing. The x-axis here is time in minutes. At the very top, we have a large bar showing therapeutic turnaround time in red and yellow. The red is the time from test ordering to result receipt. The yellow zone shows the time from result receipt to treatment. And the green zone illustrates treatment to the time of outcome being some kind of response that the patient may have to that type of therapy. The very top bar is the traditional style of testing using some kind of laboratory tests. It takes about 35 to 40 minutes to achieve an outcome following test order. When using whole blood analysis, WBA, at the point of care, shown in the compressed time interval below the first time bar, you can see that it has been reduced to about 10 to 12 minutes. Ultimately, point-of-care testing serves to bridge the gap between empirical judgment and evidence-based medicine. And evidence-based medicine is a new term created over the last maybe 10 years or so, and is defined as the conscientious and judicious use of the latest information to provide the best possible treatment. We now move on to our next section, principles and clinical applications of optical point-of-care biodetection. We'll start off with the specific example of pathogen testing. This slide shows a sheep auger culture plate. This is a traditional method at pathogen detection. It's derived from ages ago, back in the 1870s, where Robert Koch, the man who was responsible for Koch's postulates, identified a set of criteria that must be fulfilled in order to determine if a pathogen is associated with a specific disease. In short, to do this, you must first isolate a pathogen via culture from an organism that exhibits this types of disease. You must then purify it and then re-inoculate it into a healthy organism and observe if that organism exhibits the same types of signs and symptoms. And then lastly, you must be able to re-purify, reculture this organism out of this new organism that you inoculated. The problem with this method is it takes quite some time to get a result. You're dependent on the growth of the organism. You can't hurry it up to accelerate growth. And it's also very dependent on the type of media that you use. Some organisms, fastidious in nature, may not grow well in the culture media that you provided. In some cases, infection in the bloodstream can cause a condition known as sepsis. Sepsis afflicts about 751,000 Americans each year, with a mortality rate of 28 to 50%. Sepsis is an extremely severe inflammatory response to an identified or suspected source of infection. In 1999 and beyond, there have been numerous studies that have stated that if one were to have a patient with a bloodstream infection, if you were to treat them inadequately within the first 24 to 48 hours, your patient will most likely die. This was stated specifically in a paper by Dr. Marin Koloff out of the Washington University in St. Louis. The problem is pathogen detection and the guidance of antimicrobial therapy, or specifically targeted antimicrobial therapy, is highly dependent on the organism that is identified using these slow culture methods. This led us into using a new type of analyte, shown here in the slide, nucleic acids. This is a DNA strand structure built in our university at University of California, Davis, and it just highlights that this molecule is completely not growth dependent and can be amplified using technology that was developed during the 80s. Now we move on to nucleic acid recognition. Of course, this technology is not limited to pathogen detection because it can also be used to identify genetic disorders, including cancer and cancer treatment. Polymerase chain reaction serves to amplify DNA, and then the products, the amplicons, are detected using fluorescent technology. In brief, as a review, this is a schematic of polymerase chain reaction. You start off with double-stranded DNA or RNA, depending on what you are looking for. Heat is applied to denature the DNA to separate it into single-stranded forms. Then the sample is then cooled to a point to allow sequence-specific primers to bind and then facilitate DNA polymerase to begin elongation of this strand based on the template. Following copying, we now have a new set of double-stranded DNA, and the cycle is repeated again over and over. In the case of more common PCR tests, 40 cycles are completed, allowing 2 to the 40th power of DNA to be amplified. Methods at recognition of these amplicons is based on 4 main methods. They may be nonspecific or specific in nature. First, we have here turbidity, which is very nonspecific. Intercalating dyes, a very simple to use method, is also nonspecific. Hybridization probes, which is now more common, more specific. And fluorescent resonance energy transfer, which is a derivative of hybridization probe testing. It uses probe pairs, and FRET, as it's called, allows for highly specific differentiation between strands of nucleic acids. I will now go into detail for each of these 4 methods. Here we start off with turbidity-based nucleic acid recognition. On the left, we have a reaction vial containing a single strand of double-stranded DNA. Light passes through relatively uninhibited. However, following polymerase chain reaction, we've amplified the number of pieces of DNA in this sample many-fold, as you can see by the numerous strands in the reaction vial. Light is then passed through again and is very inhibited by the pieces of DNA. In actuality, this reaction vial becomes cloudy depending on how many PCR reactions were performed. Therefore, one can put this vial into a spectrophotometer to determine if you have a positive result or not. However, as stated, it's not very specific. It's really dependent on the primer design, and there's no other way to discern between DNA strands that are potentially similar but different in terms of single base pair polymorphisms. This next slide shows a diagram of DNA detection or recognition using intercalating dyes. These dyes, such as ethidium bromide and cybergreen 1, have high affinity for double-stranded DNA. They prefer to intercalate between the base pairs, as shown here. These are commonly used in gel electrophoresis, but also rather common in some types of pathogen recognition tests where you know what you are amplifying in the reaction vial. The next slide shows fluorescent hybridization probe methods. This method, as stated previously, is totally dependent on the use of an engineered probe coupled to a fluorophore. This is very specific. As you can see at the very top, we have the DNA probe. It is specific for the target single-stranded sequence of DNA. At hybridization, this will bind via hydrogen bonds. You can wash out any excess. The fluorescence will indicate the presence of the specific sequence of DNA. Our next slide builds on the hybridization probe concept using fluorescent resonance energy transfer, or FRET. We now, instead of having one engineered probe, we have 2 probe pairs. On the left, we have the anchor probe, which is has a great deal of sequence homology with the target DNA. Conversely, the sensor probe has less sequence homology relative to the anchor probe. It is shown here missing a single nucleotide. Both probes are attached or tethered to a fluorophore. The anchor probe in this case has a fluorophore that is excitable by a blue laser, whereas the sensor probe is not affected by blue light. Upon hybridization and continuous excitation of the anchor probe's fluorophore, these two probes are brought together within roughly a few base pairs, 2 to 6, maybe about 100 angstroms in distance. The resonance effect between the blue fluorophore will cause the fluorophore and the sensor probe to become excited and emit a red light. This is by design, and the instrument that is looking for this type of interaction can only detect red light, therefore there's no interference from the blue light. This allows for highly specific detection of a nucleic acid recognition, because there must be two sequences of DNA that are within 100 angstroms distance from each other for this to work. The other benefits of FRET is that it allows for melting curve analysis, where shown at the bottom, when temperature is increased at a certain temperature, the sensor probe will melt off. This is totally dependent on the design of the probe and the heterogeneity or polymorphisms of that sequence that is binding to. Therefore, it allows higher resolution between similar species of pathogens, for example. This will be discussed in the next couple slides on how melting point analysis provides a way for pathogen nucleic acid recognition to multiplex. Now we can see that in this slide, FRET and fluorescent probes provides us with a tool to detect our amplicons and differentiate between a variety of pathogens of interest. Now moving on to the concept of multiplex pathogen detection. This is a device from Roche Diagnostics called the Septifast. It looks at 25 different organisms encompassing gram-positive bacteria, gram-negative bacteria, as well as fungal pathogens. These pathogens represent the top organisms causing bloodstream infections in the United States and potentially the world. How does one target organisms that are very closely related to each other? For example, Klebsiella pneumonia or Oxytoca. They're both from the same species, but only different at the subspecies level. We can see this in the next slide. These are the DNA melting curve figures for the Septifast system. We will focus on the second row, which has a detection wavelength of 640 nanometers. The x-axis here is temperature in Celsius. These peaks are the melting curves based on fluorescence via FRET. You can see that the two peaks that are very close together are for Klebsiella pneumoniae and Klebsiella oxytoca. They are showing melting points of 58 degrees Celsius and 61 degrees Celsius. These two melting curves, as by example, show that two subspecies, due to polymorphisms in the sensor probe sequence, allow some resolution in differentiating between these two organisms. However, a completely different species of pathogen, Enterobacter aerogenes or Enterobacter cloaceae, has a melting point of 67 degrees. Since they are different at the species level, their melting point is completely different. When applying this to a variety of other different channels, detection channels at 610, 670, and 705 nanometers, you can now multiplex within a single reaction vial. This is very useful and reduces the amount of samples that you would need to use if you were to run tests for single organisms at a time. This slide shows commercial pathogen nucleic acid detection devices. On the left is a device from a Sunnyvale, California-based company called Cepheid. It is for near patient use only at this time. It cannot be used for the point of care given that it has a computer or laptop connected to it. However, it must be noted and commended that it uses a cartridge-based approach, which reduces the potential for pre-analytical confounding variables such as contamination. However, there are movements towards the point of care. Cepheid, for example, will continue on and describes that they will consider point of care based testing. But in the case of what's out there, we have a newer generation of the handheld nucleic acid analyzer that I described previously. It's shown here on the far right. This is now based off the same technology from a company called Smith's Detection. This instrument still uses markers for biothreat agents, so it targets Bacillus anthracis, Francisella tularensis, as well as Yersinia pestis. But the company, Smith's Detection, is now moving towards the clinical world with the instrument shown in panel B. This is called the BioSeq Clinical. It is also cartridge-based and targets methicillin-resistant Staph aureus, the so-called superbug that we hear on the news so often, as well as a intestinal pathogen called Clostridium difficile. Now we'll go into confounding factors in nucleic acid recognition. Confounding factors are elements within the sample or outside the sample which can cause aberrant results. This slide shows the key players in polymerase chain reaction, specifically those that have been proven to be confounding factors for PCR-based tests. On the top left, we have white blood cell genomic DNA as a potential confounder. Genomic DNA will outnumber any pathogen DNA found in blood, and they are also much larger. This essentially is analogous to one looking for a needle in a haystack. Moving down, we have the presence of DNA integrating enzyme, or DNase. This effectively eats up your target DNA and all other pieces of DNA, so you may lose your target sequence over time if these enzymes are not denatured. Urea potentially could denature your DNA polymerase, which is the primary mechanism of DNA amplification in PCR. Urea may be present in patients who have a high blood urea nitrogen level due to acute renal failure. Blood pH, as we all know, enzymes function at optimal pHs. They may vary. Therefore, in critically ill patients who may exceed or go below a normal blood pH due to a variety of pathological states, may inhibit PCR. On the right, top right, we can see that blood additives can inhibit PCR, specifically EDTA, ethylene diamine tetraacetic acid. This is a common anticoagulant for whole blood samples. EDTA works by chelating divalent cations such as calcium. However, it is not completely specific for calcium and thus can chelate magnesium, which is a cofactor for your DNA polymerase in PCR. User error is also very important and also something to consider. Patients may be difficult for a blood stick, so you may have less sample than what is required, or in some cases you may have people collect too much blood. This can, of course, reduce your sensitivity of your test or cause dilution of your sample if there's too much sample provided. Blood transfusion and fluid resuscitation in critically ill patients is also very common, and this effectively dilutes pathogen load, whether it be viable bacteria or pathogen DNA, in the patient's central compartment, that is their circulatory system. This next section now covers photometric blood glucose monitoring. This slide clearly shows how much sugar is present within a single bottle of Pepsi soda. This is one of the potential reasons why there is so much obesity in the United States as well as the world. There's too much sugar and cholesterol. Diabetes is now a global epidemic because of these dietary and nutritional issues. This slide shows the benefits of glucose monitoring. The applications of glucose biosensors include daily, hourly, and emergency determination of the instantaneous blood glucose level from a blood sample. This may include a capillary source, arterial, or venous sources, which are the predominant method at glucose testing in critical care patients. The clinical significance, of course, at least from a global perspective, revolves around the issue of diabetes. At least 171 million people worldwide suffer diabetes. This number is expected to double by 2030, with an estimated 5.7 million people believed to remain undiagnosed, with another 57 million people estimated to have pre-diabetes. From a critical care standpoint in the intensive care unit, a new issue has arisen which is independent of diabetes amongst patients. This is revolving around a concept known as tight glycemic control, which depends on hourly glucose monitoring coupled to intensive insulin therapy to maintain a tight normal glycemic range, and that's around 80 to 110 milligrams per deciliter of blood glucose. A paper back in 2001 by Dr. Greet Vandenberg established that if you maintain this glucose range in surgical patients, they did better. There was less infections, less episodes of infections, as well as better wound healing. Conversely, in the control group, which were reliant on traditional insulin control, which is merely based on the use of a sliding scale, they just added insulin based on a pre-established protocol, those patients did a lot worse. The reason being is high blood glucose levels inhibit white blood cell function, specifically the neutrophils. Neutrophils are the most prevalent white blood cells found in the bloodstream, and of course are the major players in fighting off infections, part of your innate immune response. Additionally, in patients that have wounds that need to be healed, high glucose levels prevent these wounds from healing up. This is a major component of burn patients who essentially have a wound over their entire body. Well, there are risks involved with tight glycemic control, and one of the key problems is the risk for hypoglycemic episodes, that is, low blood glucose, less than 40 milligrams per deciliter. The potential for hypoglycemic episodes are increased just because of, one, potential inaccuracy of glucose monitoring devices, as well as various pathological states that are found in these patients. Some patients may have a higher insulin resistance versus others, and vice versa. In 2008, Dr. James Crinsley at Stanford Hospital in Connecticut identified that glycemic variability may also be associated with poor outcomes in these patients. Again, this may be a physiological element, but also potentially a technological component where glucose monitoring, which is in this case in tight glycemic control, is completely dependent on point of care tests, where these tests, if are inaccurate, may contribute to variability as well as risks in hypoglycemic episodes. This next slide shows tight glycemic control ranges. The bottom panel shows various hospital ranges that are in use today. The x-axis is, of course, glucose in milligrams per deciliter. You can see our own UC Davis Medical Center using an 80 to 120 range. Stanford Hospital, Dr. Crinsley's group, focuses on an 80 to 125 range. And above, in the panel above, you see tight glucose control evidence, including Dr. Vandenberg's landmark study, as well as Dr. Pham's study, showing a 90 to 120 milligram per deciliter range in a pediatric patient group. This is actually at UC Davis from Shriners Children's Hospital, an affiliate of our healthcare system, and it shows outcomes, good outcomes in these patient groups who were placed on tight glycemic control. Now we move on to the methods underlying photometric glucose detection. The overall concept is based on an enzyme-catalyzed oxidation reduction or redox reaction between glucose and a chromogen, and chromogen being a colorless dye. Electrons are generated during this redox reaction to cause the chromogen to develop color. So you can see a general reaction scheme where glucose plus an enzyme plus the chromogen through several reaction steps induce a color change, and this color change is proportionate to the amount of glucose that is found in the sample. The enzymes that are involved with this reaction are usually glucose dehydrogenase or glucose oxidase, and the chromogens that are used are MTT and MBTH, of which we will not go into. Just know that these are color changing molecules when exposed to electrons generated by the redox reaction. This next slide shows a process of how one would take blood glucose or blood from a finger stick and test it for blood glucose. So on the left we have a finger stick. This is a disposable lancet where it punctures a portion of the finger or any other area such as the ear or the heel of the foot to yield a small drop of blood. This drop of blood is then applied to either a test cuvette or test strip. In this case it's a test cuvette shown in the middle picture, and it reacts with the enzymes and other reagents found in the test. The full reaction shown below the picture you can see is coupled to a dye which changes to blue-green when exposed to glucose. This cuvette is then inserted into the device, and after a few seconds to a minute the result is displayed. This next slide shows other photometric glucose meters, including the one I just showed previously. Panels A and B are from the same company, LifeScan, a subsidiary of Johnson & Johnson. This device uses a test strip where a finger stick yields a blood drop and it's applied to the pink area shown at the bottom of panel B on the test strip. On the other side of the test strip is a window where the reaction can change the color of that window to a darker blue, and the darker it gets, the more glucose there was to react with in the sample. And of course panel C, like I said previously, is the device that I showed, and it's the HemoQ 201. Now let's talk about confounding factors in optical glucose testing. What can cause discrepant or erroneous results? Predominantly this is due to this slide showing the blood matrix. Many things can be found in the blood matrix which can alter your results. Specifically, oxidizing and reducing agents, drugs that are found in the sample such as acetaminophen can alter your results by changing the electrons generated in the reaction. The level of oxygen can also alter results. PO2 level found in the blood can affect your glucose oxidase dependent reaction, where glucose oxidase requires oxygen as a reactant for the process, for the redox reaction to occur. As stated previously, like with PCR, since this is an enzyme catalyzed reaction, pH and temperature also play a huge role because it may alter the enzyme kinetics of your detection reaction. The blood matrix, as stated previously, also includes water and lipid content. Glucose is highly soluble in water, therefore the proportion of plasma, which is mostly comprised of water, relative to the amount of red blood cells found in the blood will potentially give you different results. So in patients who are polycythemic, have a high red blood cell count or high hematocrit, may have a falsely low result since there's less plasma to detect, and the opposite is also true. Patients who are anemic, who have a low red blood cell count or low white hematocrit count, may have a higher plasma content, which leads to the device detecting a higher amount or falsely high amount of glucose in the sample. Additionally, red blood cells in polycythemic patients could also mechanically impede your biosensor. Of course, there are many other issues that could come into play, and they are, of course, discussed in a variety of literature, including the one shown below. We will now turn to non-invasive oxygen saturation monitoring. This slide shows a simple red blood cell. This is a very interesting cell, as we all know. It carries oxygen. However, the protein design of the hemoglobin molecule, being a tetrameric protein with each subunit having its own heme group to bind a single molecule of oxygen, shows cooperative kinetics, as shown on the right, where there is a sigmoidal curve in the hemoglobin saturation versus PO2 graph. This allows the hemoglobin molecule in the red blood cell to know when to release oxygen when it is surrounded by tissue that has a low PO2, so deoxygenated or low oxygen or hypoxic tissue. In hyperoxic tissue, the hemoglobin molecule, of course, retain the oxygen that it's carrying, so as shown on the graph on the right, where the x-axis is PO2 and the y-axis is hemoglobin saturation. When in arterial blood, almost all of the hemoglobin molecules are saturated with oxygen. The question is, how do we clinically measure this? Before the invention of non-invasive oxygen saturation monitoring, this is dependent on blood gas tests, which relies on sampling from an arterial blood sample. With the invention of pulse oximetry, this has allowed clinicians to monitor non-invasively red blood cell oxygenation status based on the absorption of red versus infrared light. This is very useful, as the name implies. It can allow you to monitor oxygen saturation, but also the pulse, your heart rate. With newer technologies, there are other analytes that are measurable, including hemoglobin and carboxyhemoglobin, as well as methemoglobin. However, this goes beyond the 2 wavelengths of light, which actually, as I will mention later, uses 12 wavelengths. So here are the principles of pulse oximetry. You have a LED, which emits a red and infrared light. This is passed through a area of the patient's body that is thin and readily accessible for their blood vessels. Of course, this is right through the skin, and on the opposite side of your LED would be a photodetector. The red and infrared light that shines through the skin is dependent on the amount of deoxy as well as oxyhemoglobin. Oxyhemoglobin reflects more red light, while deoxyhemoglobin reflects more infrared light. Therefore, the amount of light that makes it through, the ratio of red versus infrared, determines how much of the blood is oxygenated. Additionally, the device also interprets the sample or the blood as pulsatile versus non-pulsatile to differentiate between arterial versus venous blood, where venous blood is not pulsatile. Being able to distinguish between pulsatile blood, the device is also able to identify your pulse rate, hence the pulse component of the word pulse oximetry. On the far right, we have a display which is very similar to most displays found in the hospital, where you have the pulse at the top, which is reported in beats per minute. Here it shows 89 beats per minute. You have the O2 saturation, which is reported in percent, and you also have the waveforms, the pulsatile blood flow that's going through that biosensor at that time. At the bottom, you also have something called the perfusion index, which I'll discuss in the next couple slides, where it shows your quality, your signal quality. The higher the perfusion index, the better and more reliable the results are. So the clinical significance of pulse oximetry is really, one, allows you to determine if the patient's hypoxic or not. Normal oxygen saturation levels are greater than 95%. However, lesser values may indicate tissue hypoxia. Low oxygen saturation levels could also be the result of poor tissue perfusion, ventilation, or other pathological states. Heart rate also is possible for monitoring with pulse oximetry. It allows you to determine if the patient's tachycardic or bradycardic, having a high heart rate or low heart rate respectively. With newer 12 wavelength pulse oximetry, which was actually recently approved last year by the FDA for use, you can now monitor in real time and non-invasively hemoglobin levels. And this is important in terms of determining if a patient's anemic and if they require blood transfusions. This is very useful in surgical patients where a hemoglobin level of less than 7 grams per deciliter could indicate the need for blood transfusion. This could be due to a variety of reasons, including hemorrhaging. Inhalation injury is another area where 12 wavelength pulse oximetry may be useful, since this new technology can measure carboxyhemoglobin. This may allow these patients who have inhalation injury, and this is usually the case in burn patients, to know if their respiratory tract has been exposed to thermal injury. Usually respiratory damage via inhalation injury is a marker for poor outcomes in this patient group. And lastly, but certainly not least, exposure to environmental chemicals may cause an elevated levels of methemoglobin. This includes exposure to nitrates and chlorobenzenes. This next slide shows pulse oximetry formats. On the left in panel A, we have a device from Massimo. This device is the device which uses 12 wavelengths to determine not only your pulse and your oxygen saturation, but also your hemoglobin, carboxyhemoglobin, and methemoglobin. Moving to the right, in panel B, we have the device from Nellcor, which is a little bit smaller, but this figure essentially shows how the biosensor can be mounted on the finger, but also on the forehead as needed. Panel C, we have a device from Nonin, which is very small. It fits on the finger and it provides very simple data, including oxygen saturation and heart rate. Well, now the question is, what can cause aberrant results in confound your pulse oximeter? Confounding factors in pulse oximetry include photo interference. This includes ambient light, motion, surgical diathermy, carboxyhemoglobin, and methylene blue. Some of the interesting things that we run into in the critical care world include motion, where you are monitoring a patient over time and all of a sudden the alarms go off stating that the patient is becoming hypoxic, levels less than, say, 80%. You rush in there and you only find that the patient's doing completely fine and they're just trying to move around and waving their arms trying to get your attention, and the biosensor, the pulse oximetry sensor, was not able to measure accurate oxygen saturations. Carboxyhemoglobin, of course, from the binding of carbon monoxide to hemoglobin, of course, carbon monoxide binds with extremely high affinity relative to oxygen, can also cause the hemoglobin molecule to maintain its bright red color. This could cause the pulse oximeter to misinterpret the red color as being oxygenated blood, so giving you a falsely normal oxygen saturation. Methylene blue is a dye which can react with your hemoglobin and convert it to methemoglobin. Of course, that is, as stated previously in the last slide, a potential exposure to some kind of chemical. Turns out that detection failure rates range from 5 to 50% for pulse oximeters. Values that fall below 85% oxygen saturation become more and more inaccurate, as shown in other studies. Detection failure rates contribute to a loss in sensitivity and specificity from 92% to 74% and 90 to 84%, respectively. Another area where pulse oximetry may have trouble includes states of hypoperfusion. This could be due to cardiovascular disease, hypoxia, sepsis, and respiratory disease. Hypoperfusion from various etiologies result in a reduction of red blood cells and pulsatile flow. Low perfusion indices lead to increased bias. To build upon this, one might wonder why hypoxia is a potential confounding factor in pulse oximetry. Well, as stated previously, as you fall below 85%, there's a greater and greater error rate in your results. Your perfusion index, for example, may be altered. So your results become more unreliable, and the only way to confirm what your results are, or to deny what your results are, is to do a blood gas test. And this is what the clinical world will push towards when you are not appropriately thinking that the device is accurate based on the results that you're getting. Now we go to our conclusions. We can see that based on what I've lectured today, diagnostic devices are progressively moving towards the point of care to address current and emerging healthcare needs such as pathogen detection and real-time monitoring. Optical point-of-care testing may provide evidence-based, minimally invasive, or non-invasive methods to detect diseases earlier, thereby improving outcomes. Confounding factors represent a challenge to all types of biosensors, including optical technologies. Ultimately, the future lies with reagent-free and non-destructive optical point-of-care testing, which may facilitate cost-effective diagnostic alternatives to the United States and low-resource countries. We now focus on future directions. What does the future hold for optical biodetection? This next slide shows the variety of optical technologies that have been developed over the years since the 1600s, and we can see a trend towards reagent-less optical biodetection. Let's start off on the left. In 1674, Anton von Leeuwenhoek improved upon the light microscope. He was able to look at biological samples, see individual cells. And of course, skipping ahead about 300 years or so, we have our first flow cytometer. It's a rather large device, and for those of us that are familiar with current day flow cytometry, we can see that this is completely useless and not capable of point-of-care testing, at least at that time. About 3 years later, we have the first introduction of the Ames reflectance meter. This is the first photometric glucose meter, as well as the first handheld glucose meter in general. It was a rather interesting development, which essentially started off the whole area of point-of-care testing, especially in diabetic patients. In 1979, in Japan, development of the first pulse oximeter, thanks to developments in microprocessor technology, this device now provides clinicians with an alternative, or at least a complementary technology to blood gas testing. Of course, you can see here, relative to my previous examples, that the biosensor back in 1979 was considerably larger than what we have today. In 1991, we have the first patent filed for infrared non-invasive glucose monitoring. Not much has been done in this field, although it's still moving forward. We have not heard much since this patent. There's been a few devices that show up here and there, but mainly prototypes rather than any devices that have been used in the clinical setting. In 1996, we have application of green fluorescent protein, which has driven various areas of biology, but also in the field of flow cytometry, where these proteins could serve as markers for cell sorting and so forth. In 2005 and 2006, we have publications that report the use of Raman spectroscopy, which has been around for quite some time, as well as coherent anti-Stokes Raman scattering, or CARS, to look at cancer cells. And this is in a labelless method, so you can discern by interrogating a cell with a laser and looking at specific vibrations in the bonds within the molecules from these cells. You're able to discern a difference between a normal cell versus a cancer cell. This is actually published by one of our partners at the NSF-funded Center for Biophotonics Science and Technology, or CBST, up in Sacramento. And this is one of the great examples that are hopefully driving the area of optical biodetection towards reagentless and non-destructive assessment. Now we have the next slide showing emerging optical point-of-care technologies. In panel A from UCLA, which is just recent, several months ago, the application of magnification greater magnification components to a cell phone, in this case a microscope attached to a cell phone camera, allows you to look at individual cells with your cell phone and take a picture. So potentially you can do a complete blood count, which measures your platelets, white blood cell count, and red blood cell count to determine the patient's hematological state. In panel B, we have a more recent image of an infrared glucose monitoring device. This is merely a mock-up, so not much has been heard, as I said previously. Panel C, this is from a company called Micronics, and this is a card-based flow cytometer, and you can see how it's compared to a laptop. It's very small. The card is shown below. This is the actual card, where you see the blue or the green, yellow, and red areas are the reagents. This mixes with your blood sample, and through cell sorting, you can then do your complete blood count more accurately and potentially do differentials if it achieves a similar capability as their larger counterparts in the laboratory. This next slide shows our center's work. It's point of care testing global opportunities, specifically for critical, emergency, and disaster care. We fund projects from outside facilities and institutions, but also within those here at UC Davis. As you can see here from Dr. Alexander Resvin at the top left is a protein microarray based multiplex pathogen detection system. This is not dependent on nucleic acid amplification. Whole blood samples are pre-processed using dye electrophoresis. This will purify out any pathogens of interest. The pathogens are then pre-concentrated onto a microarray containing antibodies specific for the organisms that we are targeting. A lysis agent is then applied to release the DNA inside these organisms. DNA detection is by zinc finger proteins. These are the proteins or DNA recognition sites found on our hormone receptors. So therefore we're using nature to essentially serve as a detection system. These zinc finger proteins are of course now engineered. They're dimeric proteins. Once they find a specific sequence, they will dimerize and come together and allow you to detect this dimerization through the use of, say, horseradish peroxidase or fluorescent molecules. The next device that is funded by our center, albeit not optically based, is still worth mentioning. It's using a surface acoustic wave biosensor. This is from Dr. Richard Larson from the University of New Mexico in collaboration with Sandia National Laboratory. The device is essentially a chip with a grid of antibodies in the center. Opposing on either side are transducers, which generate a surface acoustic wave. When these antibodies are specific for a target, let's say HIV-1, bind with the antigen, their mass is altered, thereby causing a phase difference in the wave, and this is detected by the sensor. Essentially, this biosensor serves as a very sensitive mass detector. So currently this device is intended for use for emergency blood donor screening. So in a disaster situation, you would use this to screen donor blood so that you won't give someone a blood-borne pathogen. In this case, this biosensor is set up to look for HIV 1 and 2, hepatitis B virus, and hepatitis C virus. In the upper right-hand portion of this figure is our own device working in collaboration with Lawrence Livermore National Laboratory. This device uses nucleic acid amplification, but not PCR, as we discussed. As I inferred, polymerase chain reaction relies on thermal cycling, so increases and decreases in temperature. This is not necessarily feasible in a disaster situation, such as in Katrina, where temperatures approached 90 and 100 degrees with a variety of high humidity situations. This device now relies on loop-mediated isothermal amplification, or LAMP. Through a autocatalytic reaction via loop intermediates, This nucleic acid amplification method operates at a single temperature, 63 degrees Celsius. This will allow this device to be brought to the field and be used for critical emergency and disaster care. We look for 5 different organisms, including Streptococcus pneumoniae, Staphylococcus aureus, Candida species, E. coli, and Pseudomonas aeruginosa. And for the Staphylococcus aureus, we also differentiate between sensitive versus resistant variants via the MECA methicillin resistance gene. To compare all these devices shown on this slide, we will use reference instrument when applicable. You can see our Roche Septifast assay as well as the Cepheid device. So these will be used to compare these technologies to and assess the performance and potentially validate them for future use in the clinical setting. And that now concludes our presentation. Of course, our acknowledgments are shown here, and thank you very much for your time and attention.